All right. So we are recording. And with that, I'm going to hand it over to Ashley. And I'm just so excited to hear you talk about leading nursing during the pandemic.
Thank you, Joni. All right, good evening. Hopefully you all can hear me okay. I am in my office at work, so hoping for no interruptions here. But tonight we're going to talk a little bit about leading nursing teams, particularly nursing teams during the pandemic. And as Joni said, I am a Linfield graduate of 2006, and Linfield really set me up for success as a nurse and as a nurse leader, and really gave me the foundation to build my career on. So I am extremely grateful. So first of all, I'll lead off with I am a wife and mom. That's my husband, Steve, my daughter who just turned 5, Peyton, and my son, Jason, who is actually turning 8 this weekend. And then this is our puppy, Mackie, who is part of our family as well. So wanted to lead off with that. As Joni said, I am a graduate of Linfield of 2006. I went to Linfield directly out of high school when the Linfield Portland campus was down in Northwest Portland across from Legacy Good Samaritan Medical Center. And it was a 4-year college campus with the dorms. Now it's a transfer in school and the students commute. So a little bit of progression and change since I've been there, but we got a chance to tour it last week and the new location is beautiful. I went on and graduated from Gonzaga University in 2015 with my MSN in health systems leadership, which obviously is pretty applicable to my career now. A little bit of my background. So again, as Joni said, I started out in the ICU at Legacy Good Samaritan Medical Center. I actually started there a year before graduating with my nursing degree as a CNA, a certified nursing assistant. And I'll just stop there really quick. If I accidentally move into medical or nursing acronyms and you have a question about what something means, just stop me. I'm usually presenting to nurses, and so I'll try not to do that. But if I do and you have a question, just let me know. As a certified nursing assistant for a year, and then I was hired into the same ICU as a nurse when I graduated with my nursing degree. So really a great team to grow and learn from. It's definitely where I grew up, and I did that for 6 years as a bedside nurse, a charge nurse, a heart nurse. And then about 6 years into it, the manager of that unit was promoted to a different position, and I was asked to step in and lead that team, where I did that for 5 years. Was then asked to move to our hospital across the river. Legacy is an 8-hospital system. I was asked to move over to Legacy, Emmanuel, and manage their neurotrauma ICU. Their manager had retired and they were in need of some help. So I did that, but ended up staying 3 years and really, really love it here. Almost 2 years ago to the date, so right before the pandemic started, I was promoted to Director of Patient Care Services. So really jumped into the deep end here, but couldn't be happier. And as I've said before, it really is my dream job with my dream teams and my dream leadership. But I am Director of Patient Care, of Emergency Services, and Critical Care. And just a little bit about Emmanuel, I won't go into too much depth, but just to highlight that it is a very acute hospital, a tertiary center, meaning that patients transfer from outside or smaller or hospitals that don't have as much capability to our hospital for our expertise. And we have a 24-hour emergency room. Our operating room is going all the time. Level 1 trauma and burn, stroke, neurosurgery, cardiology, cardiac surgery. This tower, I don't know if you can see my pointer. This tower is the Children's Hospital, and this is Emmanuel Adult. And our L&D is over here in the Children's Hospital, but they do high-risk OB. And then we have ECMO, which is, I'll go into that a little bit more, but that is a rescue therapy that we've been using a lot during the pandemic. And then we also offer hyperbaric, which is unique. It's essentially compressed oxygen therapy to help help the body heal, helps a lot with burns or wounds, or just sort of immerses the body in oxygen to help it heal, which is unique, and our burn team uses that quite a bit. My teams, so I think they're the best teams, of course, might be a little biased. We do have wonderful partners, and our other division of our med-surg units are equally as great. But I'm responsible for the emergency department, the neurotrauma ICU, this cardiovascular ICU, the progressive cardiac care unit. I also have the trauma, the level 1 trauma program and the ECMO program. And then a little bit of a unique opportunity is I also have the respiratory therapy department. So a non-nursing department, but the interplay is really important with all of our sick patients that are on ventilators and require different modalities of ventilation. It's nice to have respiratory as part of our team. This next slide is an unfair slide, but yesterday when we were in huddle, so every day we huddle at 9 a.m. With my team, and I give them announcements or updates, and we talk about sort of what's going on in their units. Are they red or green? And so then I can take that information and share it with our leadership here at Emmanuel. If they need something, then we can do some quick problem solving. But they were unaware that I was going to take a group shot yesterday. And I just wanted to portray one of the challenges of working during the pandemic is some people are at home, like Ace up in the top right. He looks like maybe he just got up, but here's my team. And this is just them, and they're so amazing. And I really do feel like I have the very best team. And one of them was in the car with their sunglasses. So yeah, they're incredible, and they're very committed to this place. And special shout out to the lady in the middle with the mask. That's Liz. Liz is my admin assistant, and her job is to manage myself and the trauma medical director. And I'm not sure how she does it, but she keeps us both in line and on track, and really appreciate her. So we'll start with my ED team. So this emergency department is a very high acuity ED. It is 29 rooms, but sometimes we get up around 50 or 60 patients and end up putting them in gurneys in the hallway. And somehow this fantastic team manages to take very great care of all of the patients that come in our doors. Some can be pretty challenging, some are very sick, but they make it happen every day. The unique thing about this ED is that we have an OR. You come in through the main doors, and if you're sick enough and you need to be opened up, you just keep on going into the OR. There's also a CT scanner offshoot of there. So we're really proud of that layout, and I believe we've saved many lives with that process. The ED is about 130 staff. They are led by a manager, an assistant nurse manager, and an educator. They all somehow dodged a photo, but they're amazing. In the middle there, you will see our tent. And that tent really, and other healthcare systems did it too, but we popped those up sort of in the beginning of the pandemic, and it gave us a little more room to sort of separate patients as they were coming in, those with COVID and those without, so that we weren't exposing both types of patients. And it gave us a little bit more area in our waiting room just with the big volumes. And I'll go into a little bit more depth about how we use the tent in a minute. This is the neurotrauma ICU. So the 3rd floor ICU, it's 24 beds. They actually take care of quite a number of different patient populations. They take all of the traumas, the strokes. They do a lot of neurosurgery and general critical care. And this is where we also house our ECMO patients. This is to about 120 staff, and they are managed by an amazing manager and A&M, and they also have an educator. Here is the CVICU and the progressive cardiac care unit. So the CVICU recovers all of the open hearts, all of the patients who enter our cath lab with a heart attack and other sort of cardiac assisted devices. They recover them. It's a very specialized team. It's a little bit of a smaller ICU, 12 beds, but they do quite amazing things. And the PCCU is where they transfer these patients out of the ICU, and this team also takes patients out of the cath lab. And so they work together kind of on the continuum of care and take care of all of our cardiac patients. And these two teams are led by a manager, A&M, and a couple of educators as well. Here's our RT team, our respiratory therapy team. You can see, let's see if I can find my pointer. Here's one of our RTs adjusting one of our specialized ventilators. I don't know if this patient's on ECMO or not, but super sick. The team is putting in lines and doing some sort of a procedure. They're a tremendous support. And here they are, just a great and specialty team. This team is a little unique in that they take care of patients across the lifespan. So they not only service our adult side, they also take care of the babies and the kids on the Randall Children's Hospital side. So a little specialty there. They are also part of our kids team who go and pick up sick kids and bring them back to Randall for their specialized care, and part of our critical care ECMO transport team, which I'll talk about in a second. Here's the trauma team doing their work. So that picture on the left is actually our first COVID positive or suspected COVID patient. I think she ended up having it, that we had in the ED that they had to resuscitate. So it's the ECMO and the trauma team working together. They're putting lines and tubes, and patient R is already on a breathing machine. I don't think the patient had a pulse at this point. So they're working on getting that back. And then you can see the disaster that they left in the room. But this patient did make it upstairs to the ICU. Our trauma is a level 1 trauma program, and that's one of 2 in the Portland metro area. Obviously, the other one is OHSU, but that team is led by a medical director, a trauma program manager, and they work and they oversee people that enter data. We have an injury prevention team that goes out into the community and fits kids for helmets, helps elderly with fall reduction. Really an amazing team. We also do a lot of outreach with other trauma centers and provide education and outreach. So kind of a little of a different flavor with the program versus the unit, but equally important and amazing. This is the ECMO team. So ECMO stands for extracorporeal membrane oxygenation. It's really a last-ditch therapy for patients suffering from respiratory failure, like with COVID, or cardiac failure, or both. We also use it for patients who come into the emergency department with no pulse. We try all of our tricks, and if we still can't get them back, sometimes if they qualify, we'll place them on ECMO and we'll try to fix whatever's wrong with them while artificially circulating their blood. Sometimes it's successful, sometimes it's not, but we've had some pretty good wins with it. ECMO essentially is this machine here pulls, when your lungs are failing, they are not oxygenating the blood. So it pulls, this is my very rudimentary explanation of ECMO. My team would probably roll their eyes, but it pulls the unoxygenated blood out of the body and removes the CO2 and artificially puts oxygen into the blood and then returns it so that we can perfuse vital organs. And so this team also does amazing work. This is one of my favorite slides. The guy on the top right wrapped in the blanket, he's our first ECMO patient and our first COVID ECMO patient. And we went and got him up in Yakima and put him on ECMO. And he was our first survivor out of the ICU. So this is the team taking him to the step down unit after he came off the ventilator and got a little better. And then the guy to him on the left, we had a celebratory parade for him, and he walked out through all of the staff, and he was our first survivor to leave the hospital. And he too was from either Eastern or Northern Washington, but obviously very grateful for the team there. And then bottom left is members of our transport team. They're up at a hospital somewhere else retrieving a patient. With ECMO, at first, we weren't sure if we were going to even provide ECMO. It does, and we didn't know a lot about COVID in the beginning, and it did have the potential to put our staff in an increased risk of exposure. So we really struggled a lot with whether to let them kind of go for it with COVID patients, but they insisted. This is something they really wanted to do. They wanted to give the people opportunity to live and see what they could do. So as a next a couple slides down, we're almost at our 100th COVID ECMO patient. So they're quite incredible. And this is a picture of the transport team. So a subset of our bigger ECMO team actually travels the region. We get consults and they go as far north as Alaska. They've been to Northern California, Montana, Nevada, all over the place. And they go and they place the patient on ECMO, get them stable, and then bring them back to the neurotrauma ICU where we care for them. So picking up some of the sickest patients, and they go by ground if it's within 2 hours. Anything more than 2 hours, they take a plane. That team's made up of 6 providers and about 50 nurses and about 12 RTs. So they continue to do great work. So the pandemic. So my teams, obviously, as you can imagine, are on the front lines and in most instances the front doors of the COVID pandemic. It's had a significant impact on our teams. I can remember back in March of 2020, just before spring break, thinking, what, the schools are closing, what am I going to do for 2 weeks with my kids? And then, almost 2 years later, here we are still dealing with the pandemic and trying to figure out how to educate our kids and keep our people safe and our community safe. And it's been quite the adventure, and it's definitely not over. So I just want to acknowledge that while I'm talking about my team's contribution in the hospital and their work, they are also moms and dads and family members trying to keep their people safe. And COVID's really unique that it's here in our work. We're immersed in it and we're dealing with it every day. And the teams really get no reprieve because it's at home too. So it's been a challenge to keep our team resilient. This is just I mean, for it to be small, it's not, we don't have to dig into the numbers here, but just a little graphic of the pandemic. Starts in April of 2020 and goes up to now in October. And you can see kind of the first surge and the second, we start off okay, and then it slowly builds. And then you can see the Delta variant here. We are coming down the backside of the surge, but we definitely have some other challenges that we're dealing with, which we're not out of the woods, and it's not making it easier, some of the stuff we're dealing with. So earlier this week, I pulled these numbers, so I'm sure Legacy is above this number now. I'm certain we've broke the 1,000 COVID patient number. And then again, the ECMO team's at 96. So hoping to celebrate the 100th patient soon. So really quick, whenever there's an emergency, we use the HIC system, or the Hospital Incident Command System. And this is in hospitals, it's in fire, police, other service industries, and this is small, but just sort of showing the structure here of what it looks like when we go into an emergency. And there's a lot of moving parts, and I've had the honor of serving as the incident commander. This role right here, which essentially is responsible for the big picture and really the operations of the whole hospital. And all of our 8 legacy hospitals had their EOC, is what we call it, our Emergency Operations Center, open. And so not only were we managing our own hospital, we were leading up through our system and making sure that we were consistent in what we were doing across all 8 sites, which is a challenge in itself, but something that's essential to keep our teams on the same page and make sure that we're not overutilizing resources or something in one site while somebody else doesn't have enough. So a lot of coordination going on. And then obviously I have a day job with my teams. So I rotated with 2 other people, our chief nurse and our hospital president, in that role. And it's also quite exhausting. You're kind of the last line of decision making, and you have a lot going on. So it's nice to rotate that role with a couple of people. Again, COVID's been unique that normally when you're opening your incident command, it's that, multiple people have been injured, or some sort of natural disaster, or the power goes out, and the operation, you need to help with the operations of the hospital. COVID's unique in that it wasn't one isolated hospital or one isolated county there, and you can't really pull from resources from any neighboring hospital or get something from another legacy site, because really everybody's in the same boat. So this looks complex, and it is. But here's a real life picture of our board here at Emmanuel. And me as incident commander. You get to wear these fancy vests when you're in the role. And the top left is really just trying to keep track of what patients we have and what units and what we're expecting out of the surgery, what the OR, and what's coming in through the ED, and where we're going to put all these people. And then the sections on the right are sort of those boxes that are underneath the incident commander. And each team, you get phone calls in and people saying, oh, I have this issue here, I need more supplies here, and putting quick processes in place and keeping track of what you've accomplished and what's still outstanding. And then the grid on the top right is our really amazing supply chain team. They're the ones that help provide all of the PPE and get us respirators when we need them. And as you know, it's been in the news, we've been a little scarce on protective equipment. It's better now, but in the beginning we really were having to keep an eye on what we had and what we didn't have, and trying to keep our team safe with what we had. So that's just a little snapshot of the inner workings. When thinking about sort of our 4 top challenges for the pandemic, really I put them into 4 buckets: staff, safety, patients, and beds. And these are all still a work in progress for sure. But as far as staffing, there's not enough nurses in general. And then, like I said, the nurses their kids get sick, so they need to stay home and deal with that. They get ill, or they get exposed at work and go into quarantine. Or we have nurses that just are exhausted and can't do it anymore. We've had elevated sick calls. So all of that contributes to just not enough staff. And then we really rely heavily on our team members in therapy, rehab, our CNAs, EVS, which is environmental services, like our housekeepers and dietary. And really, when they're short-staffed, we feel it too. So it really is a big team effort. So staffing is not just nurse staffing, it's staffing across the hospital. So we've had to improvise and create new care models, and ways that we care for patients, and sort of leverage the nurses that we do have in other areas to help in, let's say, an OR nurse, because now we're not doing as many surgeries. How do we get her or him to help us in the ICU? The vaccine mandate that's been all over the news, that's further impacted our teams a bit. But I'm proud to say Legacy has about a 95% vaccination rate. So thank goodness we are able to vaccinate most of our team and keep them working with us. We have a lot of travelers, so nurses who sort of take temporary jobs all over the country helping us as well. And then we continue to try and hire. Here's an example of what I was talking about as far as when you don't have enough nurses, how do you sort of leverage what you do have? So this too is a really busy slide, but essentially each unit has a charge nurse and they have primary nurses. And while normally ICU nurses take care of 1 patient if they're super sick, or 2, if you compare them up, all of our patients are paired right now. We just don't have the staff to give them one-on-one care, which some of them really need. But this model actually spreads us to like a 4 or 6 patients to 1 nurse. So really spreading it out there and trying to keep the staff and patients safe is really a challenge. So a lot of work and a lot of time we spent trying to create these models to support the staff and the patients. Again, like I said, it takes all hands on deck. When one team is short, the other teams feel it. So really thinking about, we have what's called our system office, and those are the people in like information services or billing, or sort of those people that make it happen behind the scenes and work in the office. How do we bring those people into the clinical space and give them enough training to help us on the front lines? So we've been identifying roles that they can help us with. They run labs, they help us clean, they help us screen our visitors. We were taking temperatures, making sure all of our visitors have a mask and that they're approved to go up and see the patients. And then the picture at the bottom there is myself and my boss. There was not enough housekeeping, and that is a middle of the night picture of her and I cleaning rooms in the ED because the rooms weren't getting cleaned and the patients were backing up. And if the room's not clean, we can't put the patient in the room and they can't get care. So whatever it takes. Safety. So again, just making sure our staff have the protective equipment that they need to prevent exposures. Obviously trying to minimize our staff being exposed to COVID from patients, from each other, from patient to patient. We've had, it's been a challenge. We've had multiple nurses or team members in quarantine or on leaves of absences due to either not knowing a patient was COVID positive when they come in the door, or just something happens while caring for them. There's a lot of remote meetings. That team picture, it's interesting to look at all of my team in that sort of fake seating arrangement, because to be honest, those 9 to 12 people have not been in the same room with each other in almost 2 years. So it has all been remote. Like I've seen them one-on-one or one-on-two and when I round, but we have not been together in person as a team for almost 2 years, which is a challenge. And we also have partners working from home and trying to balance keeping people safe working from home when they can, but also here to support the operation. So a lot of work going on there, and just figuring out where to put the patients so that we keep COVID patients away from patients that don't have COVID. Do we put them all at one hospital? Do we put them in one unit? Do we sort them out? How do we, not only for exposure purposes, but when we were low on PPE, it helps to have them all next to each other so that you can leverage the protective equipment or the staff that you do have. And then just keeping the staff physical distance. Nurses love a good potluck and they like to get together on their breaks and spend time together, and keeping them apart has been hard. Spreading out computers, taking away chairs, taping off places to sit so that they stay away from each other, because they just inherently group up, and we just can't tolerate people infecting each other while they have their mask down while they eat. So lots of things to consider here. Added this graphic. Legacy has about 14,000 employees and about 4,000 or so nurses. I might be off a little bit there, but just showing that we really have done a good job keeping our team safe and free from exposure. You can see the number of exposures there. For that many employees, we really only have about 36 or so workplace infections. And we're keeping our staff safe from our patients that have COVID with only 19, and keeping employee to employee infections down at 17. So really incredible work by our employee health team and all of the leaders trying to figure out ways to keep their team safe. I think we're doing okay on time here. So these are just a couple of examples of problems we solved in the Emergency Operations Center. A couple of examples here. So you can see those ED tents again, pretty proud of those tents. You can see what they're supposed to look like there in the blueprint. And then our ED manager and ED team created a process of how we would utilize that tent, the ins and outs, and where we triage patients and where we care for them. Underneath that, in the beginning of the pandemic, we actually didn't have a lot of COVID tests, like physical laboratory tests, to figure out if patients had it or not. And we definitely didn't have enough of the ones that resulted quickly so that you could know before you cared for them, which obviously can result in exposures or risk to the employee. So just sort of hammering out what patients we use the rapid test for, what ones can tolerate having a 2-day turnaround, and then getting that information to staff to make it happen. It's all very challenging. I put this picture back in here. This is that picture of the ECMO and trauma team resuscitating a patient. I put it in here because ECMO is a scarce resource. There's about 30 circuits in the Pacific Northwest, and we have 8 of them. And it's hard to figure out, who do you save, who do you not, who do you turn off on an ECMO circuit because there's someone that's younger and has a higher likelihood of surviving that's up next. And so, I mean, we had to solve a lot of problems with our ethics team, really come together as a team to really live out what we were hoping to achieve. So just a lot of heavy and thoughtful decisions there. And then you can see them in their full PPEs, because again, patients come in and you have no way of knowing if they're COVID or not. So the team suits up completely. And then this is just another example of a workflow. EMS obviously is bringing us patients multiple times a day. And you would think figuring out how to keep EMS outside when they bring us patients would be simple, but it takes a 10 square process plus some red tape on the ground to figure out where EMS pulls in. The team meets them outside, removes the patient from the gurney onto a bed and takes them into the ED. So just an example of, you think something simple and it's not, especially when you're trying to knock it out in a day instead of months with a collaborating team. Our patients, so why we're all here in the hospital, it's been really challenging. Early on in the pandemic, patients weren't allowed visitors at all. And so the nurses were doing everything for the patients, including providing the emotional support. Eventually we got to a place where we were allowing visitors, but some of our COVID patients in the early days actually died without family members at the bedside. And we had nurses holding up iPads so that families could say goodbye to their loved ones. So that is all taken. I mean, staffing is one thing, but these sort of emotional and big losses and a lot of death has really burdened the nursing team for sure. Masking, just getting the visitors and the patients and the nurses to wear their masks has been a challenge. Our patients are confined to their room. They no longer get to visit the garden or walk around to the cafeteria. Our volumes are high. Even pre-pandemic, our volumes are high. We typically see about 130 patients in the ED. And like, just for example, today, our COVID numbers are down, but we went on what's called ambulance divert. And while that's supposed to turn off the system to ambulances, we got 27 patients while we were, closed. So every hospital's in the same boat. And so it's just sort of a round robin and everybody's getting inundated. Early on in the pandemic, we stopped doing elective surgeries in order to sort of utilize the staff for the patients who had a critical need, or redeploy those surgical nurses up into the units where the sick patients were. And patients only got sicker during that time. If you put off an emergent or a not elective or not emergent case, patients only tend to get sicker. So we're seeing larger number of sicker patients now. Which only compounds our problem of too many patients and not enough nurses. And then the morgue, it's a little bit morbid, but our morgues were filling up and we had to rent refrigerator trucks and figure out a process for moving bodies from one hospital to the next to sort of house all of the death that we were seeing. So this is just a quick picture of a patient talking to his wife on the iPad in a spot where we didn't have visitors, and then just an example of one of our communications to patients to encourage them to mask to keep our patients and themselves safe. Beds, so not enough of them, too many patients. We've actually created pretty solid surge models with the nursing staff to where we're able to basically care for patients in every bed that we have here at Emmanuel. The problem is we just don't have enough beds. So figuring out every nook and cranny that we can make into a space to have patients, we've been doing that. Like I said, our ED sees multiple types of patients. We also get a lot of transfers in, being that we're a level 1 trauma center and stroke center. And we can't turn those away. I mean, they need our services, so we have to figure out how to accommodate them. Ambulance divert, it's not even a thing anymore because everybody's on ambulance divert, so we just see everyone. It's hard to get, once we admit patients and we have them in our hospital, it's hard to get patients out. Some of them just don't have a place to go to. Skilled nursing facilities and care facilities are full. They require vaccination, or the patients not to be COVID positive for obvious reasons. And so we're just having trouble getting patients in and also getting patients out. And EMS is really struggling with the same staffing challenges, vaccine mandate, and low resources that we are. So it's also made it a challenge to transfer patients out that we need to get out of the hospital or move to another hospital. So all resources are thin, and it all comes back to affect the patient in the hospital. This is another busy slide, but I promise my teams understand it. Essentially, we were figuring out where to put clean patients and non-COVID patients and where to put COVID patients. And it just moves down. Once the NTICU is full, then it moves to the burn center. Then we overflow into the children's ICU. And you can see too, there's threshold lines of once we fill up our conventional units, we have to switch to that team nursing model where they're taking more and more patients per nurse. And we're really utilizing any of the helping hands we can get as we expand patients throughout the hospital. Just wanted to comment on a few keys to success. It's not all doom and gloom. We have found some things that really work for our teams, and I'm certain we'll be stronger for it. Communication is the biggest thing. Communicate wide and communicate often. Communicate the why. Our team is about 600 people, and these changes were coming multiple a day at least. And if we can't articulate why we're making our changes, they just feel like whiplash. Like they have to understand the why to get their engagement and their buy-in. Communicate clearly and effectively, or effectively too, but efficiently. The teams are so busy, they are not reading their email, and they aren't reading it for long. So what can we put into 3 bullet points, and what is the most important thing we need our teams to know that day? Like I said, we huddle every day at 9 o'clock, figure out what we need to do, where the gaps are, what we need to communicate to our teams, and spread it that way. And just over communicate in multiple ways. So email, phone, person to person, text, whatever it takes, trying to get the information out. Take care of yourself so you can take care of your team. That's a hard one. We all give more to each other than we do ourselves, but we've all learned that we can't take care of each other if we're suffering ourselves. Take breaks and help others to recognize when they need to too. This is advice I give to my team all the time. We're a very close team. And so you can really tell when somebody's struggling or needs a minute. So we do that for each other, and we take each other out of the space and just say, hey, sounds like you need to come back in a few, or go have some protein, see someone you like, and then come back to it. Prioritize. There's no way to get everything we need to done. It's a constant daily reshuffle, and we just approach that as a team. Remain visible. So our teams are obviously working really hard at the bedside, and the most important thing we can do as leaders is stay visible. Some of our team members work remote, maybe 1 day a week, but as a team, we are here. We visit our teams at the bedside every day. We see what they need, and they know that someone's here to help them. Let people help you. That's a good words of advice that I probably need to give myself sometimes. And then write it down. There is no way to remember everything that's going on a normal day. And right now it's just a little bit crazy. So writing it down so we can keep track of ourselves and what we have going on. The future of nursing, it's a little grim right now, a little bleak. We obviously in Oregon and Washington, we've lost some nurses to the vaccine mandate, which affects our pool of nurses. And this slide says that the shortage of nurses will be 1 million by 2022. I'm not sure anybody has the right number right now, as nurses are making moves for different reasons. But essentially, our senior citizen pool of patients is getting bigger, and our workforce is getting smaller. We have retiring nurses. We have people being turned away from nursing school. We just don't have enough people to educate them. They're leaving the bedside because they're burned out and they're tired, and the pandemic kind of pushed them over the edge. And some people are even leaving the profession altogether. We have new graduates that are excited to start their careers and get into the nursing profession, but we're seeing them come in really green. Some of them have not had bedside clinicals because of the COVID pandemic. We've really had to limit their exposure, and also too, our staff just haven't had the capacity to train them. So they've done a lot of their schooling on site and in simulation, which is just a little different in communicating and touching a real patient. So like I said, I was able to tour the Linfield campus, and they've made quite some progress with some real life mannequins. So that gap is closing shortly with the advancements there, but really it's taking a little longer to orient these nurses, and just trying to hire. People are moving around less. People are becoming travelers because travelers make a lot of money with their temporary assignments all over the country. So just trying to like solidify and gather your team is really hard these days, but we're making do. I'm almost done here, but I just wanted to share a couple of quotes from my team. I asked them if they could give me a quote about what it's like to lead their teams during the pandemic. And I won't read them all, I'll just read a couple and give you a couple seconds to read. But I thought this was really good. This is from one of our newest assistant nurse managers on our team. She said, "This is a once in a lifetime experience, I hope. But the constant changes, plans, moving units, training staff, communication to all staff, supporting staff is nothing that you can prepare yourself for and know how to do. I've experienced a lot during this pandemic as a new leader, and I believe it will really help me be a smarter and stronger leader. I also appreciate all the collaboration between our units, the hospitals, and the leaders that took place. I think that really created a strong foundation for supporting each other and building relationships among colleagues." So that's really nice. And then one more, the constant heavy decision making and change is exhausting. Then to turn around and communicate it to hundreds of staff and try to get them on board quickly is hard. We've been doing this day after day for almost 2 years. So you can just really feel kind of the heaviness there. And I'll just give a few moments for you to read a couple more, and then we'll finish up with our last slide. And I think I'll end this page with one, and it's the red one there that just says, "There aren't good or bad days anymore. They're all hard. But there's always hope, and my team has hope, and they're positive, and I'm confident that they will get through it." And with that heaviness, I just wanted to share kind of a humorous slide here. This is Eric. He is one of our ICU nurses here, and he actually doesn't work here anymore. He moved back to be closer to family, but I called him to see if I could use these pictures. But the CDC actually has some recommendations and some rules about what facial hair styles are appropriate for use with a respirator. And Eric put out a survey monkey to his team with some options, and the team voted on what his facial hair would look like during the pandemic. So I think this one is called like the Zappa or something. I don't know, but here you can see it. It's something. But every day when I would round, and you have to excuse me, I don't have a mask on here. This was in the early days of the pandemic when the bedside team were wearing masks, but us walking around, which seems so long ago now, weren't required to wear masks. But I would round, and each day he was caring for super sick COVID patients, and he would bring his whiteboard to the window, and he would have a joke or something funny to say. But you can see him, "Come on in, there's toilet paper in here," or, "Hey girl, do you need help with that papper?" That's that mask hood thing he has on. And this was one of my favorite. It's small, but it says, he was really grasping here during the middle of the pandemic. "I took all the spices out of your kitchen yesterday. Nobody has noticed yet, but the thyme is cumin." So, he's really digging there. And then here's John from a couple of slides ago, one of our RTs on transport. He has, I don't know what facial design is, but I'm not sure that's an approved one. But anyway, they got creative with their facial hair. The teams are really good about keeping each other positive, and they're funny. They laugh every day, which I think is part of the reason they get through this. So with that, I will take questions.
Folks, go ahead if you have questions. Either just raise your hand or just type right in.
And I'm not sure I can see it, so Joni, you might have to help me.
Absolutely. First, I just want to say, Ashley, I had all the emotions listening and watching that, filled with awe and inspiration and just gratitude for you and everything you're doing. So thank you. If I don't say it in the end, but just thank you to you and your team. You're doing so much, which is really, I really appreciate learning about this.
Yeah, my team is pretty amazing. They make my job fairly easy.
Right. So if you want to maybe raise your hand, put something in the chat or unmute yourself and go ahead and type in. Your sister's proud of you, Ashley.
I see it.
Joni, can you hear me?
Yeah.
This is Kim Jones, the Dean of the School of Nursing. And Ashley, what a wonderful presentation. And your leadership during these last 2 years has just been incredible. And I'm so impressed that you started your nursing career right out of high school. And I think that's part of why you've been able to be as successful as early in your career as you are. And I guess my question to you is, what do you see over the next 3 to 6 months in terms of how you anticipate continuing to make modifications as the pandemic continues to morph?
Yeah, I think it's such a hard question. And I don't know if Stacy's on here or not, but my boss, we always talk about how, it's kind of day to day right now, or just getting through the week. And it's hard to sort of project or have a vision or think further than what's right in front of you right now, because we're all so busy. But I think this sort of staffing challenge, and I don't think we've seen the end of losing more nurses. So I think it's going to be a struggle of sort of outreach and recruitment and building back up the profession and attracting and hiring nurses for a good year and a half, and just trying to build back our teams and get some solid skill set back under us to move forward. But I'm hoping that we will be in a really good place in a year from now, and be looking forward and trying to, we had high hopes, not that we don't now during the pandemic, but we had a lot we wanted to accomplish before the pandemic hit, with growth of the programs and being able to care for more patients and different types of patients at a manual. So hoping to accomplish some of that once we get through this.
Yeah, that's great. And I don't know if Keisha Kelly is still on, the Chief Nursing Officer from Legacy Health Systems, but we had this same conversation about 2 hours ago. And, Linfield, we're poised to graduate about 200 over the next 12 months, 80 of which will be in December. So we're really leveraging some good residency programs that Legacy has to really make sure that people, new graduates, have the best leg up when they're starting their careers.
Yeah. Anything else? All right. Well, thank you so much.
Yeah. Oh, actually, Ashley, I was going to ask you one more question. I was trying to
Okay.
give a nice long pause just to see if anybody else had anything. But one of the things you talk about is self-care and gosh, the hard emotional internal part of this. As a leader, and all of your team members, they're each leaders in their own right, but how do you build and rebuild morale day to day, and how do you help others keep going?
Yeah, my team is pretty good. They really take on a lot, but they're also they're pretty lighthearted. They're pretty funny. We're a great team, and I think too we support each other. And a lot of us have young families, so we cover for each other. This site is really good about making sure people have time for their families. They're hard jobs. They require a lot of hours. But it's just a part of our life. So we got to make sure we have time for the rest of it. And I say that and I almost laugh, because sometimes I have trouble doing that with myself, but I have no trouble making sure that my teams are cared for. And then I have someone that does that for me. So just taking care of each other and knowing that, and celebrating the wins, right? Because we've seen a lot of death, but we've also seen quite a few miracles. So making sure that we keep those at the forefront for sure.
Great, thank you. It looks like Patrice had a question as well. How do you and your team stay up to date with changing information on COVID and up to date on the latest information with COVID?
Yeah, part of the huddle structure that we have, so I meet with my team at 9 every day. And then after 9, we go into a site huddle at 10, and it cascades from there. So every day we're getting information from not only hospital leadership, but system leadership. And so they are gathering the information and sharing it with us every day. Because like I said, it's hard to look up when all you can get through is what's right in front of you. So if it's not fed to us, I don't know that any of us would have time to figure that out. So grateful for the structure we have in place.
Thank you. Well, let's see. I don't see any other raised hands or questions. So I guess with that, I'll say it's time to say goodbye. And if you do have a question and want to hang on just a minute, feel free. Otherwise, just thank you everybody for joining us. Ashley, thank you for your leadership. You really make me proud to be an alumni of Linfield. And I'm sure so many others as well. So thank you so much. Thank you everybody for joining us. And for some of you, we'll see you tomorrow night at Linfield's Finest at 5:30 on the Evergreen campus.
Thank
All
you.
right. Thank you guys.